Welcome everybody to Total Turf Experience here at Pittman, New Jersey. I am Chris Therien, longtime Philadelphia Flyer defenseman and now an employee of the Philadelphia Flyers and NBC Sports Philadelphia as I cover the pre- and post-game responsibilities for the Flyers on most game nights and playoffs. Very, very pleased here, as I said, the Sports Medical Forum, the Energy Lab. Jim McCrossin, the Flyers head trainer, is going to be joining us, along with Jess Harrison, who's going to be joining. There are experts in this field. Tonight's topic, as we said, is going to be ACL. I'm also joined here by another counterpart, a current Philadelphia Flyer. Love these big defensemen, the great Sam Morin, who himself has gone through two knee injuries. We will touch upon that. Right now, we're going to get right into it with the experts. This week, as we're talking, you hear a lot about knee injuries in general in sports. Tonight, it is the ACL, otherwise known as the anterior cruciate ligament. And Jimmy, Jess, what exactly is the purpose of the ACL? I guess we got to find that out first.
Take that one, Jess?
Sure. I guess I'm going to need to work on my talking voice over there. So when we're talking about the ACL, this is a knee here, and this one actually is to show a knee replacement. But with the ACL, simply is one of the four major ligaments of the knee. So you have two that sit right in the center here. So if you can see inside, you have two ligaments there, and the ACL is one of those two that helps prevent forward translation of the tibia or the lower vertebral leg, as well as has a purpose in decreasing or helping control some of the rotation around the knee.
I guess, Jess, when you look at that and you hear, it seems like when you talk about the knee, the ACL seems to be the most predominant one that you hear. If someone's on a basketball court or soccer, oh, they tore their ACL, or something happened to their ACL. When you talk about that, what is the ACL's purpose, and why does it seem to be the defining factor behind the entire knee?
So the biggest portion with that is the ACL's role in creating or decreasing the anterior translation of the tibia. So what we're talking about here is the ACL will actually prevent that bottom part of the knee, the tibia, from moving forward. And so when you're looking at running, all of that is a forward moving momentum. So that's why the ACL is so important and why it's such a big injury with someone who wants to get back to sports, because you have to be able to control that tibial movement when you need to stop, because you're moving forward and then you have to stop. So if your ACL is torn, the tibia theoretically is continuing to move, but your body is not.
Really interesting, yeah.
So, you know what, if you don't mind me, I just add, it's unique. The ACL has proprioceptors in the actual ligament. And these proprioceptors actually tell, right, they go up to your brain, up to your spinal cord, and what they do, they actually tell your muscles which ones to fire, right, to help support this knee as it's going through. If you're running down a soccer, a turf field that's an uneven contour, or if you're jumping up, you get a rebound, come down, you know, what muscles have to fire to help support that knee. And that's what we're finding out, that they not always getting healed up when we're sending people back to the rehab. And it's critical. It's critical to make sure that you fully rehab this type of injury.
And I guess we'll stay right on that and lean back to the injury. How common are the ACL injuries in general, whether it's sports or non-sports related, but how often do you see the ACL injury happen in, say, a difference with the PCL or the MCL or anything else that exists in the knee?
I'll take that one. Last year there was reported over 200,000 different type of injuries to the ACL. Okay, and that could be partial strains, a full rupture, but 200,000. So that's quite a bit. And out of that 200,000, there was 95,000 right, ACL reconstructions that were performed. And I'm sorry, there were 95,000 ruptures that occurred. And out of those 95,000 ruptures, there were 100,000 reconstructions. So a rupture means a complete rupture, right? Or at 50%, you usually look at 50%. It's time to get it fixed. You're kind of on the bubble there. But over 100,000 of those, of the 200,000, had reconstructions done.
Very, very interesting stuff too. And again, I'm leading off to when you talk about the, you mentioned that 200,000 injuries to the ACL, which is fascinating. A lot of them are sports related. You see a lot in college, a lot in pro. But how many of these, and when people say what is meant by a non-contact ACL tear, what exactly would be a normal or a reoccurring not contact ACL tear?
So with a non-contact injury, it's exactly what it sounds like. It's the athlete typically on their own are going to make a cut, so there is no contact from another player. So typically what happens is you plant your leg and you pivot or turn, and the planting of the lower part of the leg and the torque of the upper body just causes that strain on the ACL, and it just can't handle it. So that's where, when we get to the rehab portion, we talk a lot about strengthening to help prevent that torque on the knee by making sure those muscles around the knee are as strong as they can to prevent you from going into that position when you're in a non-contact situation.
I guess a quick follow-up for myself is how often is it more prominent to see a non-contact ACL tear than it is an actual physical contact?
Yeah, non-contact ACLs, about 70% are non-contact ACLs. So out of that 200,000 ACL injuries, 70% are non-contact. Then it is 30% that are contact. You know, the ones that you can remember, like you see that running back or the quarterback running down the field, all of a sudden, right? They go to just change the lane. Jimmy Garoppolo a few years back he was going down the left-hand side, try to cut back a little bit to the right, and there it goes, pop. And so with that, you know, 30% are contact. If you watched, was it San Francisco 2 weeks ago? I believe it was Nick Bosa. That ACL was going to rupture no matter what. I mean, he had like a 300-pound lineman come down on his knee, and it was bent, it was twisted, and it was ugly, and he's in for reconstruction now. They're the ones that you remember. The ones you don't remember are those non-contact ones. But obviously the people that have it done, they remember.
We're going to get to Sam shortly. I have a few more questions really on some of the intricacies of the ACL and the surgeries that surround it. There's been a lot of talk, in the last 30 years. I'm sure a lot of people, Jimmy, you've been in the business a long time. When somebody's dealt an ACL injury in the 80s, that was usually it for their career, correct? A lot of the time. So we've come such a long way in rehabbing knees and shoulders and everything else, specifically knees. I have to ask you though, when you talk about, if you choose an ACL reconstruction, what is the best type of graft that you can choose, an autograft or an allograft?
I'll go first. I don't, everybody's different. And when you go to see an orthopedic doctor, the orthopedic doctor is going to fully explain to you about their graft of choice for you as an individual. And it could be that they're not going to use a hamstring, right, because the hamstring is already too weak. It could be that it's your second time and they're not going to take your patellar tendon. But before we even do that, discuss grafts, I think really we have to distinguish what's the difference between an autograft and an allograft. Jess,
So auto stands for self, so autograft is going to be your own graft type. So when we're talking about that, we're looking at you taking part of the hamstring or your patellar tendon or now even your quadriceps tendon, and that's what they use as your graft. So it's your own tissue, whereas an allograft is outside of your own body, so that's typically the cadaver graft that we're looking at. So just to reiterate what Jimmy's talking about, there's different things that we look at when trying to figure out what's the gold standard in terms of the graft type, and a lot of that comes down to the gender, your own strength, the surgeon that you choose, what their preferred method is, because you want your surgeon to be comfortable with that as well, and that's a discussion that you'll have as you go through that process.
My recommendation is don't be afraid to ask questions. Any good orthopedic doctor wants you to ask questions. Before you get ACL reconstruction, everything should be in black and white for you. You should know exactly what's the road down and why did you choose that graft, right? And don't be afraid to go, and ask the doctor, is there any studies done on between the difference between using an allograft or an autograft, right? And there is. Right now the studies are showing that an allograft, right? An allograft has a about a 2.6 to a 4.2 rate of failure. Right now, is that going to happen for everybody? But no. but it's something to keep in the back of your mind because it's going to help you make that educated decision about what type of graft you're going to use. And before I give it back to Chris, I want to give it to Sam, because Sam, you've used two different types of grafts, right?
Yeah.
And, go ahead.
The two grafts I used, the first one was the pit of the tendon, right? And the second time we used the hamstring graft because I didn't have a pit of the tendon anymore. And we didn't want to back up my left knee, which is obviously a good knee. You guys don't like when I say that, but it's like the knee that didn't get hurt yet. So yeah, I used two grafts, the hamstring and the pit of, and right now the hamstring is holding up, so that's good. Yeah.
You always want to hang on to those tendons as long as you can. You never know when you're going to need them. Which will lead us over, Jimmy, to the next one. And again, this is all now about really how to fix the ACL. Going past the initial injury, a lot of advancements are made now in the studies of knees, and we hear about them and see them all the time on TV, on ESPN Sports Center, on shows with physicians. One of the things you hear, Jimmy, the use of PRP or stem cells for treatment of the ACL. Do they actually accelerate healing? Do they work?
Well, again, you have to do your research because it's out there, and it all depends whose research you're reading, and if it's part of the stem cell manufacturer, they're probably going to say, yeah, it works, it looks like clockwork. Same thing with PRP. But PRP, the evidence does support PRP to help promote the graft and graft site or graft site healing. Right? So there is evidence that helps support that. But again, what I would recommend that you do, and Jess, right, you agree or disagree, ask your doctor, right? Ask your doctor what they find out, because they're, like any good doctor, they're going to tell you their results, and that's what you want to know. Okay, I'm going to have my ACL done. Do you use PRP? Do you use stem cell when you're doing surgery? And if you do, why? And how are your results? And how many failures have you had during the first year? Nobody wants to talk about the failures, everybody wants to talk about the successes. And don't be afraid to ask the tough questions.
And I think to highlight that a little bit, I'm seeing more now people are getting the PRP when their physicians deem it's appropriate. And the reason we see that change is it typically takes about 10 years before research actually makes its way into clinical practice. So PRP, while it's been talked about for a very long time, is only just now fully transitioning into where we're actually seeing it applied, because now we're having those research studies that are actually starting to support it more thoroughly when someone deems it appropriate.
And one more here before we move over to Sam, but this is actually one that I actually thought of last week when I was talking to Jimmy. I have 3 daughters. Two of them, they'll all be Division I basketball players. 2 of them are at Loyola, my other one's got a year left at Cherokee. But one of the things I heard every summer as they were going through the process at AAU was that if they get their menstrual cycle, they have a higher tendency to tear an ACL or have a knee injury. Touch wood, we got through those summers, and but I still always wondered why, and I did throw that to Jimmy, and I'm sure there's a lot of curiosity as to why. Jimmy, if you can help me answer that.
Again, you've got to go back to your research, and there's been plenty of research done on this because it's about 50% up in the air. Okay, but we do know a few things. We do know that females have a 3 to 6 times likely to rupture their ACL. We do know that when estrogen is present, and that's during the menstrual cycle, okay, that there is more laxity within the ACL, plus in the ankle too. All right. So, but the key about this is that not every menstrual cycle is the same, right? So the levels of hormones fluctuate, right? But there's also another component you have to take into consideration would be high school kids, high school girls, right? Are they training the same as high school males, right? Research shows, and I don't like to keep on putting out research, but if you research geek like myself and read all these journals and read the articles, and it's showing that in a high school gym, in a collegiate gym, right, 50% of the male athletes will use that gym to train. Less than 10% of the female athletes are going to use that gym to train. And are they being trained properly? Are they being mocked for being in there? You know? So there's a lot of different considerations. So if you add weakness along with laxity, it spells trouble, because it's going to spell trouble. And that's what you don't want, right? So you're diving in more and more about the hormones, right? And about the menstrual cycle. And again, that's another one that you can speak to your doctor about, to your physical therapist, your athletic trainer about, because these are the people that are keeping up to speed on all this latest research that are coming out. But the one thing I think both of us can agree on, right, Jess, is that the training. Right? Before we get there, the training is so critical, right? And you have to make sure that the person that you're working with, or if it's a group, if it's you, the individual working with a trainer, make sure that they're training you. We discussed it earlier. Neuromuscular training. Right? Just want to take a little bit of neuromuscular training.
So just to make sure we're clear, while females are a little bit more at risk because of the hormone levels, that doesn't mean that men aren't at risk either. So that's where strengthening is really important, and focusing on that neuromuscular reeducation. So what that is really is just a fancy word to make sure that the muscles around those joints are doing what they're supposed to be doing. So if we're talking about the ligaments that are inside the knee, which are being acted on by those hormones, that ligament is going to be slightly more loose because the hormone itself is making it that way. So you're getting a fuzzy signal in terms of where that knee is, to make it sort of a more simple picture. So you want to make sure that the muscles around the knee are able to also give that input. So when we talk about proprioception, that's the ability of the tissues around a joint to communicate to the brain where it is in space. So if your ligament is not able to do that fully because it's being acted on by hormones because of your age, or where you're at in your menstrual cycle for females, the muscles around that are going to be able to compensate as you build your strength. Those muscles are going to be able to communicate better where you are, so that you can control that knee movement at a non-contact point when you're changing direction on an uneven surface. So that's where making sure that you're working either with a physical therapist or a strength and conditioning coach who really understands strengthening around the knee as well as up around the hip.
Just a quick follow-up to that on the training regime before we get to Sam was, how important is it, especially for girls when you look at it, or guys? You used to see the old regime where people were doing squats, really putting a heavy load on their lower body, and I guess other injuries would come, including knee injuries. Is there a different philosophy now in the training mode to take players through that?
I don't know if I'd say necessarily different. I think that it's a little bit more complex. So you'll still see people doing squats. They might be using something different like a sandbag versus a barbell, because it will force you to use a different range of motion at the ankle, the knee, and the hip so that that whole chain is working together. But you need to be able to squat because that is teaching your muscles how to control those joints through its full range. So those are going to be just as important as doing a balance exercise, which can be simple all the way up to complex, such as doing a single leg stance on a post or a half ball. So all of those things need to be incorporated together to have a well-rounded program.
Just one thing about rehabilitation too is that if you do not feel right, or if somebody says, well, it's been 4 months, you got your strength, you got your range of motion, and you're done. No. Let's seek a second opinion. Make sure that you're fully rehabbed, right? Go to a qualified person such as Jess, orthopedic doctors. Make sure that you're fully rehabbed, that you got your strength, you got your endurance, range of motion, everything, and you pass the different tests that are out there to test the ACL, right? To test the leg, to test the orthopedic chain. Am I ready to go back and play? Am I ready to go back and play ice hockey? Am I ready to go back and play soccer? Right? There are tests out there, but for somebody to say that 4 to 6 months that you fully rehab, it's not working that way. They're actually saying now, with the research is saying it could take up to 1.5 years for you to be fully rehabbed, right? And people say that when you have a Tommy John surgery. Now the same when you have an ACL, or you hear people come back in six months. It's not that way anymore. One, you have to make sure the graft is fully matured. But also, like Jess was saying, you've got to make sure that everything's functioning the way it should be functioning, so you're not a repeat performer.
All right, now we're going to thank you guys. Great stuff. And we'll have more for you. We'll get some questions. We're going to move on to Big Sam right now. I can tell you right now, doing broadcasting games, that when I saw Sam this year in his injury, I was devastated for him as a young person to have seen. I know Jimmy, you guys on a personal level work with him every day, but from a standpoint of having been a defenseman, having been injured not to this level, my heart went out to him. And I think that the great part about it is I can see the determination and how much he wants to get back. And maybe. You know, I always said with Bill Meltzer, people at the end of the show, that the great expectation would be for you to come back, play great hockey, and win the Masterson Trophy. That's what I'd hope for. And why not, right? Like, why not? So, Sam, we'll say it. You've had 2 ACL reconstructions on your right knee. Could you tell us a little bit about the injuries and how's your rehab coming along? I know you're one of the best in the business, but I'd love to hear from you, maybe types of both of them as quick as you can, and how both those experiences have gone for you.
Okay, yeah, so the first time I turned my ACL was a huge contact. That was 2 years ago, right? It was in the playoff in the American League, and that was a huge blow. It was not like we were seeing a non-contact injury. I just tried to get the guy as hard as I can, and you can't see me come the last minute, and I just didn't see him coming. I wasn't prepared, and I hear a big pop and a lot of pain right away, and I remember calling Junior right after, and I was like, and I described to him what I was feeling. He was like, I don't think it's good. And I kind of knew it too. I felt like that. I was like, I think I turned my ACL, but I was still like ready to do the rehab right away. I knew what was getting into. The second time was a little more tricky. Was kind of a non-contact injury and no pain. I know because the second time I tear it, probably I don't know I don't feel like the tissue and the pain tissue and stuff. So it was a non-contact injury, and and now I'm here. And my rehab is doing pretty good. Honestly, it's the second time I turned my ACL, so obviously it's going to take longer, right? But the good thing right now is the season that didn't start for a long time. I have more time to feel good, and when I decided to do it again, do all that stuff over, I told myself I'm going to be honest with myself, and not like last time a little bit. I remember with hockey players, they always like we get teach to be tough and don't tell what's going on. So I remember my rehab a little bit with Jimmy. Sometimes I was not always honest with the pain level. I remember like sometime December we were skiing, and Jimmy every day asked me if I felt good, and sometimes I'm like, yeah, I felt good, but that day I was a little bit more sore, and it kind of made me like didn't help me in the rehab first time. And this time I really told myself I'm going to take it more like slow, steady pace. And it's been a year at November 28th. So I'm almost there. I mean, there's still a lot of work to do, but I feel like I'm getting closer. Like my knee, like I feel my ACL and this and all that stuff is strong. So that's good. I just need to keep working hard. I think I'm really close to something good here. Yeah.
Well, I know one thing, your attitude's been great, and I think that's probably half the battle, I bet, Jimmy, when you get involved with having the right attitude about rehabbing. I've seen nothing but a positive young man here the first time. I haven't seen much of him with the second time until today. I didn't know he liked you. I'm terribly sorry about that, so we'll get by that. Anyhow, Sam, thank you. It's great to have you here, and what we'll do now is we're going to open it up to some questions. So if anybody has anything, please, either you can come on up and grab the microphone and over to the side here and ask us a question. If you guys have anything. Otherwise, we're going to keep talking about knees. Come on up there, young man. Good to see you. Tell us your name.
My name's Travis. I got a couple questions. The first one is, do you have a better chance of tearing your ACL on grass, AstroTurf, ice, something? Does that have anything to do with anything?
I believe it does. I believe that on part of the sport that the ice is very forgiving. And the ACL injury in hockey is not that prevalent. On grass, it's more prevalent than on ice. Ice will give. If you can remember, I'm going to date myself, the old Veterans Stadium and the AstroTurf that was on there, that guys would be running, Kate McBride. and ruptured his ACLs. And so there's some different types of turf. Now the turf today, or the next turf today, is much better than the old AstroTurf of years ago, right? But you get some grass fields, and that we've all played on when we're kids or whatever, and the contours, the divots, everything like that, that's setting you up for a kill. And but most of your football, most of your high school football fields are pristine anymore, and they have the next turf. And but like I said, I hate to say my sport, but our sport, the ice is a gem. It's a blessing. I mean, you have one other question.
Go ahead, yep. This one's for Sam. You said you didn't feel any pain the second time you tore your ACL. Did you know it was torn when it happened? Did it pop? What happened with that?
No, I didn't know. I kept playing, and just like with the tibial, my tibial was just going forward, and I kind of took tape, and I just taped my pads over, and I was like, I don't think it's good. And I finished very good. I picked 2 chef, and actually picked 2 good chef, I think. And the doctor looked at my knee, and I could see this. I didn't know right away. Doctors did touch you, and they didn't know. I could just see that these highs were kind of panicking a little bit. So I remember I told Jimmy after too. I was like, oh, it's just a bruise in my knee, and I tried to stay positive, but it was huge the next day. It was just all buffy and so on. And I knew, I knew the next day. I didn't know right away. I thought it was just a bruise or something because I kept playing here.
I had one too, and again, talking about the injury, wondering, I actually questioned for both of you as well. 2 years ago, my second daughter went down in an AAU basketball game. I remember I called you. I had to go over to the city. She could not walk. The lady, it was the last minute of AAU. The lady came out, the trainer said she tore her ACL. You gotta get her home. So this is in Washington. I drove her home. Couldn't see the doctor the next day in the morning. And Ava could not go to the bathroom at all on the way home. So I'm just too much pain, I can't move. She finally got in, I kind of carried her in, she went to the bathroom, something popped in the knee, and she was able to go back. What happened, she had a dislocated kneecap. That played very much like an ACL, and we were certain it was. Jess is laughing. Can you fill us in on it? Because this looked like it was going to be devastating, and it ended up being nothing.
I'm going to try to be kind to whoever looked at your daughter, because I feel like seeing the difference in a dislocated kneecap versus an ACL tear should be pretty prevalent. But as Jimmy mentioned before, everyone's going to be different, and that's true with the injury. So some people have a lot of pain immediately, they feel a pop. Some people don't have any pain and feel like they can keep playing, and that's actually where they get secondary injuries. But there isn't any solid research that says you can't walk on a torn ACL or not if it is torn. That's not a way to determine if it is torn or not. So I'm sorry that your daughter had to go through all that just to find out that it was her kneecap, but everyone's going to present a little bit differently. Now, for Sam, he said that he could tell the day after, so usually if you've had it before, you know that feeling again after it's happened, which is unfortunate. You have to be put in that situation to say, oh, I know this is my ACL because I felt it before, but that tends to be more prevalent.
My point was letting you parents or anyone know that there could be something else, that somebody may tell you it's something different, and it wasn't. So we're glad it ended up being the way it was. We have time for one more question before we wrap things up. Anybody? Yeah. Go ahead, please. There you go.
Hi. Sam, I was wondering about the mental aspect, because I mean, it's a long road. You're pretty positive, but how was it going through it? I mean, there had to be downtime or something. It's a year. Did you see anybody else to help you discuss it besides just physical therapists?
Yeah, I mean, I've been lucky since day one when I got drafted. I always had a very good relationship with Jimmy and all the staff. Like, I just got like my teammates and stuff. They've been awesome since day one. Obviously, my parents were. I got really good parents that they're driving all that big road to come see me and support me and stuff. I got a really good family, but for sure there was some downtime around. There's even right now there's some up and downs. It's not always like nice, but I actually love the game, and I really want to play hockey again. I really want to. I feel just to be back with the boys on the road and stuff like this. Just go to dinner and just be part of the team again. It's kind of something I look forward to it, and I just got a great support right for our organization and my family and my teammates. Yeah, I think it's still a lot of work to do, but the hardest part is done. Like I'm skating and right now, so that's fun. I love it. Yeah, so.
Well, that'll wrap up our week one here of our speaker series. We're dealing with injuries from the Sports Medical Forum. For Jess, actually, and also like to thank our sponsors. We can't do that. The great Total Turf, which has hosted us here tonight, Jerry McGuff. We have Recon Sports, the Energy Lab, where sports meets science, and Brilliant Smiles by Sydney. So thanks to all our sponsors. For Jess Harrison, Jim McCrossin, Sam Morin, I'm Chris Therien. We'll be joined by the great Ian LaPerriere, a Masters and Trophy winner as well, who will be in next Wednesday. Thank you. We should be up at 6 o'clock, I believe, next week. Thanks to everybody. Enjoy the show, and we look forward to seeing you next week.